Hello, everyone. Professor Big here. Today's lecture is going to be on the respiratory system. We will briefly cover the basic anatomy and physiology of the respiratory system. You should be able to identify key anatomical components, explain mechanics of ventilation, such as pressure changes and lung compliance, and recognize common clinical manifestations and diagnostic tests used to manage respiratory disorders. In your next lecture PowerPoint, we will dive more deeper into respiratory disorders. So please go ahead and complete the readings in your module and the key points that I uploaded in there. Please review that as well. These are the learning objectives. We're going to begin by dividing the respiratory system into two distinct zones. We have the upper airway, which serves as the conduits, consisting of the nasal passages, the sinuses, and larynx. Its primary function is to warm, humidify, and filter the air we breathe in while protecting the tissues in the passages. The lower airways function as the exchangers, moving from the trachea down to the alveoli. Unlike the upper tract, the lower tract is sterile and transitions from cartilaginous support in the bronchi to support smooth muscles in the bronchioles. So this is your entire lower airway. To remember the core purpose of the respiratory system, we're going to use the acronym GAP, right? G is for gas exchange. The lungs must acquire oxygen for cellular metabolism. Your cells cannot survive without oxygen. And it needs to remove carbon dioxide waste from the blood. A is for acid balance. The lungs help regulate systemic blood fluids, maintaining the very strict pH of 7.35 to 7.45, as we mentioned in our fluid and electrolytes lecture. And this does so by retaining or exhaling carbon dioxide. P is protection. The system filters environmental air and uses the upper respiratory system to trap and expel foreign material. Because remember, that is your defense mechanism. At the terminal end of the respiratory system in adult lungs contain approximately 480 million alveoli, providing a massive surface for area for gas exchange. Because remember, that's the purpose of your respiratory system. Main purpose, at least, is gas exchange. The epithelium here is a single layer of simple squamous tissue to promote easy diffusion of oxygen and carbon dioxide. Critical component here is the surfactant, a detergent-like fluid that reduces surface tension. Without it, the alveoli would totally collapse, a condition known as atelectasis. Ventilation is entirely driven by pressure gradients. Inspiration is an active process. The diaphragm contracts and flattens, increasing the thoracic cavity size and dropping intrapulmonary pressure below atmospheric levels, which pulls the air in. This is the anatomy part of the respiratory system. Please review your anatomy if you're having difficulty grasping this concept. Expiration is usually a passive process. The diaphragm relaxes, and the neutral elastic recoil of the lung tissue increases the pressure above atmospheric levels, which helps to force the air out. First, it's important to understand the two opposing tissue dynamics. Lung compliance is the ability of the lungs to expand easily. Stiff lungs with decreased compliance require a massive muscular effort to inflate. Your lungs have to inflate and recoil. Elastic recoil is the natural inclination of the lungs to return to a resting state. A loss of recoil, common in certain pathologies, leads to dangerous air trapping and hyperinflation. So you want the lungs to expand and recoil in order for air to go in and out and gas exchange to happen properly. We use specific volumes to measure lung function, but this is called tidal volume, and it is roughly 500 milliliters of air moved during a normal, quiet breath. Vital capacity is the absolute maximum amount of air one can expire after a maximal inspiration. Finally, the residual volume. This is critical. It's a critical reserve of air, about maybe 1,200 milliliters, that remains in the lungs even after a forced expiration. And this helps prevent structural collapse and sustain continuous gas exchange because you can't just empty the air out. Some is going to stay there as a backup, and that's your residual volume. Gas exchange occurs through diffusion. Following Dalton's law, gases move independently from high pressure areas to low pressure areas. In the lungs, oxygen moves from high PO2 in the alveoli into low PO2, the pulmonary capillaries. Simultaneously, carbon dioxide moves from high PCO2 in the capillaries to low PCO2 to the alveoli to be exhaled. And this is how gas exchange happens, right? The oxygen needs to go from your lungs into the blood and your pulmonary capillaries to go to the heart. And at the same time, carbon dioxide needs to move from the pulmonary capillaries and go into your alveoli so your lungs can exhale it back out. For gas exchange to be efficient, ventilation and perfusion must be perfectly matched. That's your VQ ratio. The lungs utilize autoregulation to maintain this balance. If an area of the lung is poorly ventilated, for example, you have low PO2, local pulmonary arterioles will automatically constrict to shunt blood away to better ventilate areas, increasing efficiency. So this is called the VQ ratio. Oxygen and carbon dioxide travel differently in the blood because oxygen is relatively insoluble in plasma. 99% of it travels reversibly bound to hemoglobin as oxyhemoglobin, and carbon dioxide is more versatile. While some dissolves in the plasma or binds to the hemoglobin, 70% is converted into bicarbonate ions, which plays a vital role in maintaining the blood pH, similar to what we discussed in our fluid and electrolytes lecture. Under normal conditions, CO2 drives respiration. Central chemoreceptors in the medulla constantly monitor the cerebrospinal fluid to maintain a proper pH. If they detect a slight elevation in PCO2, which is called hypercapnia, the medulla instantly signals your phrenic and intercostal nerves to increase the rate and depth of breathing to blow off the excess acid. So if there's acid over there, too much, acid called hypercapnia, then the nerve signals are basically going to tell your lungs to, okay, let's breathe, let's get in some oxygen, let's blow off some carbon dioxide. So this is a natural process of the body, a defense mechanism. There's a backup system called the hypoxic drive. Peripheral chemoreceptors monitor, then this is in your peripheries, right? That the one we talked about before is your central receptor in your medulla. These are in your peripheral areas, you have chemoreceptors that monitor oxygen levels and only respond to marked decrease in O2, called hypoxemia. So patients with chronic lung disease often adapt to high CO2 levels, right? This causes their medulla to stop responding because it just gives up. It's like, okay, your CO2 level is constantly high, right? And so they become entirely dependent on low oxygen levels to breathe. So administering excessive supplemental oxygen to these patients can dangerously remove their stimulus to breathe. And this is what happens in our COPD patients. So the lungs are the primary managers of the systemic pH. And how do they do this, right? They do this through gas exchange. By regulating the rate of breathing, the lungs control CO2 levels, which essentially function as an acid, right? So hypoventilation, when you're not ventilating enough, retains CO2, increasing the acid, which lowers pH, right? Because low pH is acidosis. So hypoventilation retains the CO2 and lowers the pH, which causes respiratory acidosis. Hyperventilation blows off too much CO2. You're ventilating way too much. You're blowing off a lot more CO2, and this decreases the acid, raising the pH, and this is your respiratory alkalosis. Now, when preparing for pathology, we characterize failures into a triad. Okay, we have ventilation failures, obstruction, or tissue property changes. For example, asthma and emphysema. So these are all ventilation failures. Diffusion failures are disorders that thicken or flood the exchange membrane. So for example, pulmonary edema is a diffusion failure. Then you have perfusion failures. These are blockages of blood flow. For example, if you have a pulmonary embolism, if you have a blood clot, it blocks the blood flow. To manage these disorders, we're going to follow a simple framework. Okay, so observe the manifestations, right? You can observe their reflexes, breathing patterns in patients. Investigate through diagnostics. We want to verify the information, right? You're seeing symptoms, you want to verify that information. So this will be done through imaging like chest x-ray, CTs, or labs like your blood gas exchange, your ABGs, and then intervene with targeted therapies. For example, it can be pharmacology, it can be surgery, it can just be even like repositioning the patient for better ventilation. So reflex responses like sneezing and coughing signal irritation in the tract. So we have to monitor sputum. Note that hemoptysis, bright red frothy sputum, is specifically associated with pulmonary edema. Okay, if gas exchange fails, the hypoxia cascade begins, right? Starting with hypoxemia, that means low blood oxygen, and it progresses to hypoxia, where you have low cellular O2, and ending in metabolic acidosis. Chronic markers for this include cyanosis and clubbed fingers. Sputum characteristics are a major diagnostic tool. Yellowish green thick sputum suggests a bacterial infection, while rusty or dark colored sputum is a classic sign of pneumococcal pneumonia. Thick, tenacious sputum is common in asthma or cystic fibrosis, and purulent sputum with a foul odor often indicates bronchiectasis. It's important to differentiate between types of breathlessness, right? Orthopnea is when lying down due to pulmonary occurs when lying down due to pulmonary congestion, right? So the trigger is lying down. Paroxysmal nocturnal dyspnea is a sudden acute onset during sleep, typically linked to left-sided heart failure. Kusumal respirations are deep, rapid breaths, and air hunger characteristic of the systemic acidosis. Now, acoustic, anomalies tell us where the problem is located. For example, stridor is a high-pitched crowing noise, indicating upper airway obstruction. Wheezing indicates small airway obstruction. Rales are light, crackling sounds associated with serous secretions in the lungs, while rhonchi are deeper sounds from thick mucus. A total absence of sounds in the lungs indicates lung collapse. So we have to funnel our investigations in our patients from broad to precise, right? We're trying to figure out what is causing the problem, right? And so tier 1 covers functional gas exchange, tests like spirometry and oximetry, right? Gives you a basic idea. Tier 2 moves to targeted imaging like X-rays and CT scans to evaluate tumors and pneumonia. So now you're digging deeper to get, trying to verify the information. Tier 3 involves precise invasive measures like the bronchoscopy for visual inspection or thoracentesis for fluid removal. 2 essential lab tests are arterial blood gases, which directly verify hypoxemia or metabolic acidosis, and microbiological cultures, when we do cultures, sputum cultures and stuff, which identify specific pathogens to determine the most effective targeted therapy for infections like TB. Remember, all of this is related to diagnosis, right? We're trying to figure out what is wrong, and we need to get specific information to be able to treat a specific disease. Treatment follows a ladder of escalation, we call it. We start with maintenance and prevention, avoiding irritants, immunizations, things like that. Next is physical support, humidifying the air, chest physiotherapy, like the clapping, repositioning the patient. All of these are really important. If needed, then the patient will need pharmacological interventions, right? And then finally, if that doesn't work, then we will jump into advanced or surgical procedures like tracheotomies or lobectomies, things, procedures like that. Our drug therapies target specific mechanisms. For example, bronchodilators stimulate receptors to open constricted bronchioles so you can breathe. Expectorants, thin the thick mucus for easier removal. Glucocorticoids and decongestants reduce mucosal edema, right? And then an inflammation, while antimicrobials are targeted therapy for bacterial or viral pathogens. In clinical practice, these concepts synthesize into a continuum. For example, if we observe wheezing and thick sputum, we investigate with the spirometry and ABGs to confirm chronic obstruction, and then intervene with bronchodilators and specialized breathing techniques. This integrated approach ensures targeted, effective patient care. It's extremely important, just as a side note, to really investigate what's going on with our patient. We can't just say, oh, they're having difficulty breathing. Oh, they have hypoxia. It's extremely important to notice these signs and symptoms and kind of figure out, okay, what is specifically wrong with my patient? How can I find out what's going on? How can I verify the symptoms that they're telling me they're experiencing, right? Or the signs that you're seeing. So this is where, as a nurse or a clinician, we develop more insight by learning these things. And that is it for our respiratory lecture. Please review your key points, complete your readings, and I hope you started filling out your study guide because this will help you understand the respiratory system and respiratory disorders, which we will cover in our next PowerPoint.